Ladies and gentlemen, dear friends, dear colleagues, welcome at our webinar of the European Society of Gynecology. As you know, these are a series of webinars who are in preparation of our next Congress at the end of November, beginning of December in Amsterdam. And today the webinar will be dedicated to one of the most important topics in gynecology, which is the management of menopause in breast cancer survival. As you will see, we have two masters, Edward Mension and Camille Castelo-Branco, both from the prestigious University of Barcelona. Edward Mention is a specialist in OBGYN, focused on oncoplastic breast surgical oncology. He's professor in grade in medicine and breast cancer master degree in University of Barcelona. And later on, I will present our second speaker with Professor Camille Castelo-Branco. Edward, you have now the microphone. Please, you can open your, give access to your slide. You can do your presentation. Then I will present Camille, and then we will have the general discussion. Please write your question in question and answer. Thank you very much. We will see each other and discuss at the end of the presentation. Eduardo, tienes el micrófono.
Well, thanks a lot for this kind introduction. I am Edward Mension from Hospital Clinic in Barcelona, and it's a pleasure today to talk about menopause symptoms in breast cancer survivors, that it is one of my specialties. So just as a brief introduction, I will talk to you about an historic introduction about why we do fear hormones in breast cancer, and we will talk about the epidemiology of these menopause symptoms in these patients that are mainly vasomotor symptoms and genitourinary syndrome of menopause, that we will enter then in detail and talk about its treatment options. And we will finish with the guidelines consensus in the States and in Europe. So the first uses of hormone therapy are from the mid-90s, and since then it became very popular during its first years. We know that around 1990s, it was believed that the hormone replacement therapy in menopause was like a source of eternal youth, and its use increased drastically. But since the first studies evaluating and relating hormone replacement therapy and breast cancer in the first 2000s, 2002, it appeared like a really big fear of the hormone use, and its use decreased drastically. One of the first trials was the Women Health Initiative in 2002 that demonstrated an increased risk in those patients undertaking hormone replacement therapy compared to those not undertaking hormone replacement therapy. And as well in the UK, the Million Women study showed that there was an increased risk after using some different hormones, even only tibolone or estrogens plus progesterones to have more breast cancer. So at the same time, the first studies in 2002 tried to report which were the prevalence of the menopause symptoms in these patients. And in this study shows that compared to regular population, breast cancer cases had more hot flashes. So we can see here that 96% in this report of the breast cancer survivors showed hot flashes. This very interesting paper from Biglia showed that between premenopausal and postmenopausal breast cancer survivors, there were as well some differences, and as well inside these subgroups, we could see that those patients undertaking not only hormone therapy, but as well chemotherapy presented more menopause symptoms. The most common were those related to hot flashes, and we can see up to 90% of the premenopausal breast cancer survivors undertaking chemotherapy and hormone therapy presented these hot flashes, and almost half of those patients presented vaginal dryness. These symptoms were a little bit smaller in postmenopausal breast cancer survivors, but still the prevalence was bigger compared to those patients like healthy patients, not breast cancer survivors. As well, some other papers showed that these patients who were already survivors of breast cancer not only presented more incidence or prevalence of symptoms, but they presented as well more severe symptoms. Here in this paper, from a cohort of patients, survivors of breast cancer, 41% of those showed extreme hot flashes and 25% quite a bit hot flashes. So after this brief introduction, we'll focus on the main symptom that this patient suffers. First of all, in the first years after initiating the hormone therapies related to decrease in the estrogens in relation to breast cancer, that it is the vasomotor symptoms. Of course, how it is logical, we can differentiate those treatments between non-hormonal options and hormonal options. We know that as well, we can divide these non-hormonal options in natural related options and pharmacological options, and we will see afterward that hormonal options we can include maybe phytoestrogens. The easiest treatment that we can recommend to our patients is, of course, lifestyle changes. Even in some papers, they have to try to compare the two randomizing arms to do lifestyle treatment versus not lifestyle treatments. There were no differences between these groups, at least statistically, but it is an easy way to treat these patients, and normally they feel more comfortable with this safe option. Another interesting option that has been proved to be effective in different randomized clinical trials is acupuncture. It is a treatment that is not really used in our Occidental healthcare systems because it is difficult to have access to it, but some randomized clinical trials show that it can be safe and effective for these symptoms in this kind of patients compared to placebo. So it is interesting to know that this option is real. And finally, one of the last natural options that we can recommend is those supplements containing Cimicifuga racemosa or the black cohosh. There is not strong evidence in different systematic reviews, the last one in 2014, but a last paper published on the 19th showed differences between groups in a randomized clinical trial, showing a decrease of the number of hot flashes and showing that the estradiol levels were totally comparable between placebo and Cimicifuga racemosa group. So this is another interesting option. After these natural options, we have other non-hormonal options that are actually more pharmacological. They are more like stronger options, but of course they will have more severe side effects. We can find in this group drugs like vitamin E, clonidine, gabapentin, venlafaxine, fluoxetine. There are different trials assessing its outcomes, and the ones that have more evidence is clonidine and venlafaxine. But we have to know that, and we have to tell to our patients that maybe these drugs are more effective than the natural options, but they will suffer probably of the side effects as dry mouth, constipation, or others. Going now to the hormonal related options, we can enter in this part the phytoestrogens, but actually we have no studies assessing its use in breast cancer survivors. And we know that many people relate the phytoestrogens with an increased risk of breast cancer, but actually we have some studies, population studies in Asia, assessing the risk of breast cancer in a big population, comparing patients or persons who have a big soy consumption intake compared to those that are not taking this intake of soy. And actually, this study showed that these patients had a decreased number of recurrence in breast cancer. So, well, at least this is controversial, and what we don't know is what we can, we don't know if in these patients, this is actually a risk to take phytoestrogens, but should be considered as one of the last lines to our patients, as well as the hormone replacement therapy. In this case, we have some meta-analyses that show that the use of hormone replacement therapy in breast cancer survivors statistically increase the risk of breast cancer recurrence. But if we analyze in these studies the subgroups, it is interesting to note that actually this increased risk is almost only in these patients that present hormone receptors positivity. And in those cases with negative hormone receptors, maybe it shows this meta-analysis that maybe this HRT would not increase. But these are some very controversial issues, as we will see now in the guideline consensus. So what does the guideline say? The North American Menopause Society do not advise hormone therapy in breast cancer survivors, but leaves an open gate in those cases with severe and unresponsive symptoms that do not respond to non-hormonal options. And of course, in consultation with oncologists and after being fully informed about risk and benefits. On the other hand, European Menopause and Andropause Society, of course, recommend non-hormonal options as a first-line therapy, and tells us that hormone estrogen-based therapies are contraindicated in patients taking antiestrogenic therapies. Now, going to the last part of the presentation, we'll talk about genitourinary syndrome of menopause, that this is one of the other big bag of symptoms that these patients suffer. And first, before going to the option treatments, I will make a brief reminder of what is that. Actually, this is a new syndrome that includes not only vaginal dryness, but as well dyspareunia, sexual dysfunction, and as well urinary infections. It is important to note that this is like the old brother of the menopause symptoms, because there are some papers assessing how do we treat it, the physicians, and we know that almost half of the physicians who we treat breast cancer survivors, only half of us explain to our patients that it is a possible side effect to their medications, and only 1 out of 4 physicians address the problem with some solution. So this is very important. So what are the options that we have? And we will see that they are quite easy in most of the cases. Of course, we will start with non-hormonal options, normally with moisturizers with hyaluronic acid. So it is a very easy treatment, only with a recommendation of a moisturizer and lubricants when doing intercourse. And sometimes we can include a physiotherapy. It is a non-hormonal and with no adverse effects treatment. That is true that in the studies have just shown a short-term efficacy, but we will see that at least at short-term, most of our patients will improve. When with these first-line therapies, there is not enough relief, or the relief stops, we enter to a different part. We go now to a cascade of options that there are not many evidence in all of them. We can find the vaginal laser, that it is a CO2 laser normally, or erbium laser. There are different studies, but the most studied one is in the CO2 that actually provokes heat shot proteins activation that provokes a cascade of remodeling of the cells of the vaginal layers. And it is believed to increase this vaginal layer and improve then the symptoms of the vaginal dryness. But there is still controversy because of the lack of randomized clinical trials compared to placebo and the controversy between them. On the other hand, we have prasterone. Prasterone is a precursor of testosterone that during according to the intracrinology therapy theory, it transforms itself inside the cells of the vaginal layers into testosterone and estradiol. Because of this theory, the rise in serum estradiol would be very low, and theoretically it would be safe in breast cancer survivors, but still we have a lack of big evidence to recommend strongly these treatments to our patients. The same as ospemifene, that it is a serum that acts as an agonist in bone and vagina, stimulating the vaginal cells, and theoretically antagonists in the breast. So that should be safe for our patients. But again, there is not many studies assessing these treatments in breast cancer survivors, and it is still controversial. We have here one of our studies that we presented in our hospital that assessing the use of prasterone in breast cancer survivors undertaking aromatase inhibitors. In our population, we found that in these patients, at least, there were no rise of estradiol in the serum. So from our experience, this would be a safe option, and it has demonstrated to be effective in other studies. But of course, this is only a study, and we need more evidence to support this evidence. On the other hand, regarding the laser, we did as well a randomized clinical trial comparing vaginal laser to sham laser. And in this case, we found that there were no differences between the two groups. So it showed our study that there was no increased efficacy compared to placebo for the laser. Finally, talking about the local estrogens, that actually it is the most effective treatment. Of course, we know that for vaginal symptoms in menopause women, estrogens would be the most effective treatment, but of course there is controversy among its use in breast cancer survivors for all the reasons that we have talked about. So this would be one of the last options in our cases, but it has to be considered if there is no improvement and there is a severe symptoms in these patients. There is controversy as well, because there are some studies, retrospective studies, that show no recurrence increase after the vaginal local treatment use in breast cancer survivors, but some trials showed that this local use of hormone as a estriol would show an increase in serum estradiol. So there is a little bit of controversy still. So what do the guidelines say? The North American Society, of course, recommend again the first-line therapy with non-hormonal option, and say us that low-dose vaginal estrogen therapy may be considered if symptoms persist. Of course, with more concern in those patients who undertake aromatase inhibitors, because they are patients with positive hormone receptors. And about prasterone vaginal laser and ospemifene, they say that there are not enough evidence, so they have not a strong recommendation. The EMAs said again the same, to start with non-hormonal options that are quite easy and quite effective, and the hormonal therapies are contraindicated according to their guidelines. So as a conclusion, the main thing that I want you to remember is that these symptoms exist in menopause breast cancer survivors, and it is a real problem that normally is underdiagnosed and undertreated. Most of these cases will be treatable with non-hormonal options that will improve the quality of life of our patients. So it is quite easy to start at least a treatment. And if this treatment does not work, we have many other possible options to try to escalate and try to improve the quality of life of our patients. Even that there is scarce evidence in these recent options that are appearing. And here I leave you my personal opinion algorithm. Actually, it is what I am trying to do in my consultation, even that some of the things are controversial, of course. And that's it. And I hope you enjoyed the talk. Thanks for your attention.
Compliments for your presentation. And then now it's my pleasure to introduce Professor Camille Castelo-Branco. As you know, Camille is full professor of obstetrics and gynecology, senior consultant on gynecology and obstetrics, and director of the Department of Surgery and Medical Surgical Specialties, head of the Obstetrics and Gynecology Teaching Unit, director of the master's degree in clinical sexology, which is not common in nowadays, and the postgraduate degree in sexual education, University of Barcelona. He is author of more than 200 indexed international publications. He had more than 530 conference in national and international scientific meetings and webinar also today, and is author of more than 232 scientific works. Then Camille, I thank you very much. You have the microphone for your presentation. And then I invite all of you to send the question also for the Eduardo presentation, which will be discussed later on at the end of the Professor Camille Castelo-Branco presentation. Thank you.
Thank you, Andrea, for your kind presentation. And thanks also for include a webinar on the health of postmenopausal women who survive to a breast cancer. So I think that is a very interesting topic. And for this reason, I am very grateful for your consideration to our group. Yes, so breast cancer is the most prevalent cancer in the world and the second most common incidental cancer among women. In fact, in 2020, more than 2.3 million women was diagnosed of breast cancer, and considering the current statistics, it is estimated that for this year there will be more than 3,000 women diagnosed of new cases of breast cancer. In addition, near 12.9% of women, that means 1 in 8 women, will be diagnosed with breast cancer in their lifespan. Over the last few decades, thanks to the improved breast cancer treatments, breast cancer survival rates have increased dramatically, as you can see in this graphic in the right of this slide. And in fact, more than 90% of women survive at 5 years after the diagnosis. As a result of this increased survival, new challenges are emerging for women with breast cancer. So we need to focus not only on their survival, but also on their long-term quality of life. Spain and Italy, so the South European countries of the European Union, are the countries with the lowest mortality among those women diagnosed with breast cancer. So, as I commented before, due to these increased survival rates, new demands or situations that previously are unnoticed are nowadays on the focus, such as quality of life and sexuality, that is the focus of this speech. So the overall survival of women with breast cancer has increased over the last decades, despite this increased prevalence of the disease. This improved survival is largely due to the advances of the current therapies, especially since the introduction of the anti-HER2 target drugs. So many breast cancer survivors are still premenopausal, of premenopausal age at the moment of the diagnosis, and have the potential risk of receiving antineoplastic treatments that may affect the ovarian function, or antiestrogenic treatments that mimic a postmenopausal state. This hypoestrogenic state can lead to climateric symptoms, inducing significant alterations in their quality of life. They'll be affecting the compliance with adjuvant therapy. On the other hand, many breast cancer survivors are already in a postmenopausal state at the diagnosis, and the treatments used to treat breast cancer worsen the basal hypoestrogenic state, with enhanced associated problems. For young women, there are several situations related to this hypoestrogenic situation in breast cancer patients, such as the bilateral oophorectomy or the iatrogenic menopause after chemotherapy or radiotherapy, or the use of antiestrogenic drugs. This hypoestrogenism in breast cancer survivors leads to a constellation of symptoms related to this condition, such as hot flashes, insomnia, blue mods, fatigue, articular pain, various skin, vaginal bleeding, weight gain, headache. In fact, all these symptoms explains that according to the World Health Organization, there are more lost disability adjusted years by women due to breast cancer than for any other type of cancer or disease. This is related to the breast cancer. Now, what about the background of female sexual dysfunction? So, regarding the origins of female sexual dysfunction in women diagnosed with breast cancer, it should be emphasized that the 4 classical domains of the sexual dysfunction, such as pain, orgasms, excitation, and desire, may be affected collectively. As I can try to explain along this lecture, is not only this pareunia, the zoo related to the sexual dysfunction in breast cancer survivors. Female sexual dysfunction is a multifactorial entity that is influenced not only by breast cancer, but also by the psychological impact of the disease and the treatments that patients will receive to manage this condition. But of course, we should agree that in female sexuality, not everything is desire, excitement, orgasms, or pain. Female sexuality is a much broader concept that includes more global aspects such as reproductive, identity and femininity, body and genital image, intimacy, relationships, and all these aspects should not forget in patients with breast cancer, not in relation to the surgical treatment, but in general. So let me explain how different treatments may affect sexual function in breast cancer survivors. So surgery. Surgery origins a direct disruption of body image, specifically among those women undergoing mastectomy. This alteration is magnified by the fact that the breast, apart from being one of the key erogenous parts of the female body, are considered to be symbols of femininity and sexual identity. So, but we can consider that surgery may affect the sexual dysfunction in breast cancer survivors, by not only by the anatomic change of the breast, but also for the pain related to the scarring, the sensibility alterations, and also surgery not related specifically to the breast, but also for premature ovarian insufficiency when this woman should undergo salpingo-oophorectomy. There is an interesting study comparing the effect of mastectomy to surgery, to conservative surgery, or the general population, people who have never undergone breast surgery. This study was done by Ayers in 2014. And this group observes that patients with mastectomy present more severe affectation in their sexual health and sexuality than those women who was submitted to those women who undergone conservative surgery. Interestingly, is the study of Ayers that assess the effect of reconstructive surgery on sexual function. In this study, this group analyzed the effect of the immediate reconstruction, the delayed reconstruction and not reconstruction at all, and find that and didn't find differences in the moment of the reconstruction to in the affectation of the female sexuality. The effects of the other therapy that may affect sexuality in women is the radiation therapy. The effects of radiation therapy on sexual function never occur in a naive patient. So it's difficult to assess the actual effect of the radiation, because most of these patients have previously undergone surgery or chemotherapy. So the effect alone of the radiation therapy is difficult to define. However, there are some aspects related to the radiation therapy that might explain worse sexuality, such as the skin lesions, the tissue discomfort, the sensibility alterations or pain in shoulder or in the areas of radiation that may explain these worse sexual function in patients who undergo radiotherapy. In summary, radiation therapy may affect sexual function by several mechanisms, including not only the skin lesions, but also the tissue discomfort, alterations of sensibility, and the touch and pain that I just previously commented. Chemotherapy also take an important part in the development of female sexual function, sexual dysfunction among breast cancer survivors. The adverse effects of systemic chemotherapy include tiredness, alopecia, decreased libido that may be related to premature ovarian insufficiency, and all these adverse events affect undoubtedly the female sexual function. In summary, the impact of cancer treatments on sexual function is not only related to the direct effects of chemotherapy, surgery, or radiation therapy on the neuroendocrine, neurovascular, and neuromuscular components of the sexual response. It is also the result of an indirect effects of such therapies on physical and mental well-being, including climateric syndrome that has been previously commented by Professor Mension, weight gain, negative cosmetic side effects, loss of attractiveness, this body image disruption that has been previously commented, different coping strategies of the patients, anxiety, adverse effects of psychotropic and pain medications, etc. And finally, endocrine therapy. Endocrine therapy for hormone-dependent breast cancer is a keystone to reducing recurrence. However, the use of gene-range analogs and tamoxifen or aromatase inhibitors have a short and long-term impact on sexual function that have been difficult to quantify due to complexity and the variables conditioning the human sexuality. It is important to note that about 2 out of 3 breast cancers are hormone receptor positive cancers. Their cells have receptors for estrogens or progesterone, which facilitate cancer cells to grow and split. So there are several types of hormone therapy for breast cancer. Most of them act lowering estrogen levels or blocking the estrogen from acting in breast cancer cells. This dramatic decrease in estrogen levels imply a series of changes that are on the basis of the genitourinary syndrome of menopause that has been previously commented by Dr. Mension. And this genitourinary syndrome of menopause is a key piece of the female sexual dysfunction among breast cancer survivors. But it's important to note that is not the only issue of these patients. Is important, is one of the main complaints, dyspareunia, linked to this genitourinary syndrome of menopause, but is not the only complaint. When we assess how breast cancer diagnosis and treatments affect sexual function, we observe that all the dominions of sexual function are equally affected. Orgasm, arousal, desire, all of these aspects are also affected. For this reason, it's important to consider that sexuality is not only a biologic phenomenon and should be considered from a biopsychosocial point of view. And it's important to consider other aspects, not only these anatomicals or physiologicals that could have previously commented, but also some other aspects such as the sexualization of the breast as a symbol of femininity, or the social beauty standards. The last part of this speech is focused on the therapy and on the management opportunities that we have in breast cancer survivors. Some of these aspects has been previously explained by Dr. Mension, so in some slides I will devote a very short time. When we consider the treatment of genitourinary syndrome of menopause, in this case, as Professor Menson previously commented, we have published a systematic review in Maturitas just 2 years ago, considering the different options that we have to manage the genitourinary syndrome of menopause. So non-hormonal has been previously commented, moisturizers, lubricants, vaginal laser, or spermifene, and from the hormonal point of view, local estrogens or D-therapy androsterone, local D-therapy androsterone, or also local testosterone have been used for patients with breast cancer. Dr. Mention has previously commented on the lubricants and moisturizers are the first line of treatment according to all the guidelines. It's important to note that the lubricants should be used those with water-based more than silicone or oil-based, because these water-based lubricants decrease genital symptoms to a greater extent than the other ones. And in addition, seems to be associated with a better response on sexual parameters. Lubricants and moisturizers are safe. They are are non-hormonal and safe, but most of the studies on lubricants and moisturizers are a very short time. They are maximum 12 weeks, and the follow-up is very, very short. Regarding the use of estrogens, local estrogens have been previously commented by Dr. Mention. Local estrogens in general is the gold standard, but not in breast cancer survivors, as he has previously commented, and maybe considered as a last option if we don't get an improvement with the other therapies, but in any case with consensus with the oncologists who are responsible for the management of the patients. He has commented previously that there are no evidence that an increase of recurrence in retrospective studies, but also it's important to note that most of the prospective studies demonstrate an increase in estradiol serum levels. He has also presented this slide regarding the use of these different options, the vaginal laser and androgen nanospermifen. And we have also, is not to surprise that Dr. Mention and me present similar slides, because most of these papers was prepared by us. So recently we published also in Climateric a paper on the different opportunities that we have to manage these patients. And I don't want to explain more than has been previously commented by Dr. Mention. Regarding the laser, it's important to know the lack of evidence of in its use on not only in breast cancer patients, but also in the general population. In fact, we have also published a systematic review in Maturitas 2 years ago, analyzing the different paper published on the effect of laser. And it is to note that vaginal laser seems to improve many non-objective parameters, such as visual analog scales or questionnaires. But when we use objective measurements, the laser has never demonstrated higher efficacy compared to placebo. In this sense, we, and Dr. Mention have previously presented, we develop a randomized study to assess the real effect of laser in breast cancer survivors. That has been done in February of this year. In February of this year, we have published in JAMA the first data, the first 6-month data of this study, analyzing the effects of laser comparing with a sham laser, an active laser compared with a sham laser. And it is important to note that we didn't detect any difference, not only in subjective measurements, such as a visual analogic scale of dyspareunia, vaginal health index, the body image scale, or the quality of life short form 12, but also in the objective outcomes, including vaginal biopsies. And when we compare the use of active laser with a sham laser, it is important to note that we didn't detect any difference. And this study is in the same line that others wasn't published by the group of Fiona, and who also didn't find differences comparing a laser with the sham laser. So there are very, very few studies assessing the real effect of laser. in breast cancer survivor or in postmenopausal women in general. And when we focus only in randomized clinical trials, no difference was observed. Of course, in non-randomized clinical trials, it's in observational studies or in retrospective studies, the effect the laser have demonstrated an improvement in symptomatology. But when we are focused on well-designed studies, no difference were observed using laser. What is the evidence with the local androgens? Well, there are several studies, a short term showing safety over a very few periods of time, 12 from 8 to 12 weeks, and there are also an improvement in subjective measurements. In this sense, and Dr. Mension has also previously commented, we realized a study on the effects of progesterone in breast cancer survivors who are receiving aromatase inhibitors. And we observed regarding safety, we observed that in any case, the estradiol levels was higher than the security level that we established at the beginning of the study. In any case, we need to stop the study in any patient. And in all these patients, there are an improvement, a significant improvement in subjective parameters such as a visual analog scale of dyspareunia or the female sexual function index. There are several algorithms proposed by different societies. This is the algorithm of the Spanish Menopause Society to consider the management of breast cancer, or the management of genitourinary syndrome menopause in breast cancer survivors. During the treatment, they propose non-hormonal, such as lubricants and moisturizers. If this is not enough, can be used estrogens at short term, but this is important, the consensus with oncologists, and the use of laser. But laser, as we have commented previously, is a lack of evidence. There are a lack of evidence. And after the treatment, we can also use ospemifene as as a first line alternative, since it's approved in the European Union. But as I commented previously, we should take the sexual problems in breast cancer survivors from a biopsychosocial point of view. And it is important that these patients will receive not only the impact of the diagnosis of breast cancer, but also the different treatments. And all of this is a stressor that acts at all levels. Also, not only in the biological, but also in the psychological and even in the relationship, interpersonal relationships. So it is important, this broad management, considering all these aspects. In fact, as I commented previously, all dimensions of sexuality can be potentially affected, but the final balance depends on many factors, including the pre-diagnosis sexuality. The vital moment of the illness is not the same if the patient have their reproductive desires completed or not. And is also important the treatments that these women will receive. Is they are taking anti-hormonal drugs, or especially the aromatase inhibitor. this causes a significant genital syndrome of menopause, which affect the lubrication and dyspareunia. And secondarily, this dyspareunia might affect the other domains. So, and this dyspareunia leads to the loss of the positive sexuality. So it's important the management of all these conditions. Moreover, this the change in sensitivity and the self-image are quite constant, but needs to be considered in these patients. Other options in the management. The first and most important is the early assessment and the individualized care. We have many options to manage these patients, not only the focus on the genital syndrome of menopause. So to promote healthy lifestyle is important. Diet and physical activity are related to a better, not only better health, but also better sexual health. Physiotherapy is also important. So, for example, lymphatic drainage in patients with lymphedema, back and spine massage for people who has undergone radiotherapy or mastectomies. This also improve the sexuality of these patients, and also pelvic floor exercise is also important for patients with severe genital syndrome of menopause. Other options has been previously commented by Dr. Mention in the management of genital syndrome of menopause, such as pharmacological and non-pharmacological. And finally, it is important, do not forget in these patients the psychosexual intervention. Not all the patients at the end will need psychosexual intervention, but most of the patients accept this coaching, and when is offered spontaneously, when in a team treating breast cancer patients offer this management, patients are usually very grateful. So finally, regarding these concepts and products, some has been previously commented, such as the treatment of genital syndrome of menopause. So we do not stay more in this, but let me to show you the evidence on other aspects, such as physical therapy and educational and psychotherapeutic interventions. There are evidence that with physical therapy, we have improvements in the body image perception, and with educational and psychotherapeutic interventions, we improve many of the sexual health parameters. And finally, as the professor mentioned, previously commented, we are dealing with a problem that is infradiagnosed, infratreated, and most important, mistreated in many occasions. And it is important to note that we have available safe and effective options. And if this is not enough, we can consider second-line available options. So thank you very much for your attention. And again, Andrea, many thanks for organizing this webinar.
Thank you, Camille. This webinar was very important as we have focused the attention of a very important aspect in breast cancer survivors. And then now we will go to the question. We have received a huge series of questions. I start with one which is from Edward, from Faiza Al-Ghetami. He thanks for the nice presentation. He's asked you, what is your experience with gabapentin?
Well, thanks for your questions. And well, we do use gabapentin, but normally we do use it more for like neuropathic pain, but normally I don't use it for vasomotor symptoms. I don't have experience in using gabapentin in vasomotor symptoms, since I usually try to use natural options as the first option, and in my second line would preferably be venlafaxine, and otherwise fluoxetine. But I don't tend to use gabapentin because the side effects are quite severe.
And then we have another question, Camille. This is probably also for you. Ospemifene was mentioned as well as an hormonal therapy as well as a non-hormonal therapy. Can you give the explanation?
Oh, thanks, Andrea. This is an interesting question. And when Dr. Mention is doing his presentation, I also have a question regarding phytoestrogen that are qualified as a hormonal therapy. In fact, phytoestrogen and ospemifene interact with the estrogen receptor, but structurally are not a hormone. So there is not the structure of these drugs, phytoestrogens and ospemifene, is not the structure of an hormone, but has the ability to interact with the receptor, modifying the response. So we can consider as hormone because they interact in the receptor and induce the protein synthesis. In a very narrow sense, yes, but if we consider the structure of the molecule, not at all.
Thank you. And then now on a question, Edward, for you. How do you treat genitourinary syndrome of menopause in breast cancer survivors in your center?
Yeah, well, thanks for the question. Yeah, we tend to use, as I said, sometimes non-hormonal options as a first-line therapy. We normally recommend a combination of hyaluronic acid-based moisturizers, normally once every 3 days, as in form of vaginal ovals. And then we do recommend as well an external cream based as well on hyaluronic acid. And we normally recommend as well at the same time, if it is possible, a sexual consultation with a sexologist that we may have in some cases. And as well, we try to recommend vaginal stimulation with a vibrator that we have actually demonstrated in the JAMA paper as a first-line therapy, that both groups undertook this therapy while undergoing laser and versus sham laser, that these patients improved after this treatment. So we normally try to do this combination.
There's also a very important point, that the introduction of some help in these patients to cover the general difficulties in sexualities who rises after the concept to have a cancer, to have been treated, and also to be, in some cases, hormonally depleted. And please, Camille, do you want?
No, I wish to highlight that regarding the study that was published in JAMA, that even in the vaginal biopsies, we observe an improvement under the use of vibrators. So we have detect no difference with the laser and sham laser, but the use of moisturizers plus vibrators increase also the thickness of the vaginal wall. So we don't forget the use of vibrators. Regularly, when we are thinking in the management of genitourinary syndrome of menopause, no, as a first line, we are thinking in moisturizers and lubricants, but we don't forget the use of vibrators.
This is something very important information for all our people present, and also for the patient. And then Camille, another question: is dyspareunia the only sexual issues in breast cancer survivors?
No, of course not. I try to explain that dyspareunia maybe is the main reason of consultation, but is not the alone. It's not the unique issue. As I commented, there are many aspects that affect sexual function related not only to the diagnosis of breast cancer, but also to the therapies, and affects not only dyspareunia, but also the interest of the arousal of the desire are also affected, and the orgasm also affected by the neuromuscular, neurovascular, and neurologic affectation of the different therapies. Chemotherapy, hormone therapy, surgery affects significantly these pathways of the sexual function. So all the dominions, all the dominions of the sexuality are affected or may be affected by the therapy of breast cancer.
Thank you. Thank you very much also to put the attention about sexuality. One of the problems that we have to face is the majority of the doctors. They have very poor information and knowledge about how to manage sexual problem in the other person. And another question for you, Edward. Do you think there is a role for prevention of genitourinary syndrome of menopause? That not only to wait and treat, but to try to prevent.
Yes, exactly. That is a very interesting question, and this is one of the things that we will try to respond. We are trying to start a new trial in our hospital to use as a prevention moisturizers for these patients that are at high risk of present genitourinary syndrome of menopause. For example, we know that patients which are undertaking chemotherapy and hormone therapies, we have presented that they have almost half of them risk of present vaginal dryness. So maybe in these cases, we could already give to these patients a prevention in form of vaginal moisturizers to prevent to be then facing a severe GMS. So maybe this is the future. Yeah.
Thank you. And also, Camille, something also for you. This is from Roland Reis-Summer. What about fezolinetant that you have not mentioned? Fezolinetant will be very soon now out. We hope so.
Yeah.
And then, please, can you make a comment on that? Because
this may be an alternative, a future alternative. Not at this moment because we are only in the phase 3 studies, but maybe an interesting alternative. In fact, the mechanism of action is very similar to that to the cimicifuga racemosa at the hypothalamic level. So cimicifuga has demonstrated to be safe, and these new drugs should be safe also. But at this moment, we have only data from the phase 3 studies.
Thank you. And then, Edward, for you, there is a difference between local treatment with promestrine, estriol, or estradiol.
Well, yes, every kind of estrogen have different potencies, but in reality, at the doses that we are using them, most of them will act similar to our patients because they are presenting a very severe form of GSM. So normally you won't notice any difference in reality. But yeah, every different kind of estrogen have different potency.
Yes, but it should be probably also we can mention that probably the difference could be in the circulating levels of these hormones, even of minute amount. Certainly, promestrine, estriol, and estradiol have different affinity also on the receptor. This probably is something that we have to consider. And Camille, another question is from Faiza Al-Ghetami. Thanks for your presentation. What is the treatment or preventive measure to decrease the recurrent urinary tract infection in breast cancer survivors?
Well, this is a really nice question and difficult to answer. In this case, I think that one of the questions previously that you asked to Dr. Mention, I think that this is the key for this question, the preventive treatment. So the idea is to start previously to development of the severe genital syndrome of menopause, to avoid the LUTs, the low urinary tract symptoms. The idea is to start before or at the beginning of the treatments in order to avoid the development of severe genital urinary syndrome of menopause. When this is established, so we can use treatments such as dimanosa or some natural products, but this is not finally this is not it's not so useful to manage these conditions. And I think that the key is the prevention of these situations.
We have some problem with the connection. I mean, we will wait 1 second. I will make a question to Edward. Edward, it is.
I can not hear properly.
Thank you. So, sorry for some problems with the connection. Yes, and then just that, okay, we are approaching to the end, and then Edward, for you, it is usual that breast cancer survivors accept using hormone for vasomotor symptom when they have tried all the other treatment and they found no positive results for them.
Well, this is a good question because we have seen that all the evidence shows that there may be a risk, and the patients, as I showed you in the beginning of my presentations, there is a big fear of hormones among breast cancer survivors. So normally they don't accept, and most of the patients that present severe menopausal symptoms prefer to be with these severe symptoms rather than try hormone treatments. So our job here is to try to select these patients which may be a target, a safe target for these treatments. For example, and nowadays it's like a target that we are trying to understand more is these patients with negative hormone receptors.
Thank you. And Camille, for you, what is the most effective tool to manage sexual dysfunction among breast cancer survivors?
Sorry, Andrea, I listen not so
What
good.
is the most effective tool to manage sexual dysfunction?
What is the most effective tool? Yeah. I think that the most effective tool is a chair and an open ears, no? So let to the patient speak and listen to the comments of the patient. In fact, the conversation have a therapeutic is a therapeutic tool. So I think that the most useful is to ask the patients about her sexuality, ask the patients about her sexual related problems, and also to study as a doctors the different alternatives to treat these conditions. So the most important tool is a chair and an open ears, and let to the patient speak.
Thank you. And then another question, Edward, for you. What do you think about local radiofrequency treatment?
Local radiofrequency is a treatment that would be with some differences, but comparable to vaginal laser treatments. In our review assessing different vaginal lasers, we found that most of these studies were assessing CO2 lasers, but some of them, not many, tried to assess the radiofrequency. But I would say that there is scarce evidence as for vaginal lasers and CO2-based lasers to answer these questions. But the data that we have at the moment may show that the efficacy may be limited. So for the moment, I would recommend its use just in experimental environments.
Thank you. Okay, then, Father, first of all, I would like to thank both of you. And also, this was a fantastic webinar done on a very particular topic of great importance in our clinical practice. And I would like to have a general comment about your point of view, each one of you on your topic. We will start with Edward, we will close with Camille. I would like that you give your personal message to all practitioners who are with us today. We are still more than 220, and who were with us all that hour, hearing you and following you. What is your personal message to increase their desire and volunteer to approach the patient and to take care of them in the proper way? Please, Edward.
Well, yes, I would say that for me, the most important thing is, as Dr. Castelo-Branco said, is to listen to our patients. And I would add as well to ask for these symptoms. We know that almost 50% of the patients present genitourinary syndrome of menopause, and you have seen that more than 70% of the patients who undertake hormone therapies will present vasomotor symptoms. But actually, these symptoms are totally underdiagnosed because of our fault, because we don't ask our patients about these symptoms when they sit in our breast cancer consultation. So for me, the most important message is that you have to ask to your patients if they feel these symptoms, because they even don't realize that these symptoms sometimes are related to the drugs that you are giving to them. And they don't even know sometimes that letrozole or aromatase inhibitors may provoke vaginal dryness. They realize that a few years after starting this medication. So ask if they feel these symptoms, and when you give these treatments, advise these patients that and explain to them that they may feel these symptoms, and it is very common, and they don't need to be ashamed or like to hide these symptoms, because we have options. Sometimes they are not very effective, but we have something to help them.
Thank you. And Camille, and from you, you are one of not so many of us who are linking to the gynecology, the surgery, oncology, and also sexology. Please, I would like a comment starting from the heart on the topic, how we have to help our patients in a holistic point of view.
Well, it is to note that Dr. Mension and me are working at the same hospital and working very close. So it's difficult to say something different that they have previously told before. But I think that one important question is to keep in mind is that the patients, the survival rate of breast cancer nowadays is more than 90% in some countries, in Italy and in Spain, for example. More than 90% of the patients diagnosed by breast cancer are alive at 5 years. And these patients are, as I commented, emerging questions such as quality of life and sexuality that until now was not considered by physicians, but for the patients, yes. So it is important to take in consideration these biopsychosocial aspects such as quality of life and sexuality. And it's important not only because it's a need of the patient, but also some patients don't continue the treatments, the treatments that are needed for maintain the survival, such as aromatase inhibitor that has been commented previously by Dr. Mention. These treatments produce severe cases of gender syndrome of menopause and some patients abandon the treatments due to these adverse events. So it is important ask to the patients about the adverse events of the therapies, ask to the patients about their sexual health, And if the patient refers some of these questions or some of these issues, give treatments because of is important, not only for the sexual health of the patient, but also for the complementation of the treatment.
And also for the whole family. Then, dear friends, Edward, Camille, gracias. Thank you for your presence with us today. With that fantastic webinar, we close our series of Before Summer. And I remind to all of you that we will meet together at the 15th Congress of the European Society of Gynecology in Amsterdam. The Congress will be presential, but also online. It will be from the 29th of November to the 2nd of December. It will be a fantastic event where all these topics will be discussed, such as also the breast cancer and breast cancer survivor. Then Camille, Edward, thanks a lot of being with us today. Have a good summer, happy time in Barcelona. And to all my friends, to all our followers, thank you of being with us. We wait all of you in Amsterdam. Thank you.
It was a pleasure, Andrea.
Thanks a lot.
It was a pleasure.